Good morning, everybody. I'm George Dalekos from Greece, and I will present you the wrap-up session on immune-mediated and cholestatic diseases. I will start with potential new diagnostic markers for autoimmune hepatitis, and you see here European multi-center study on polyreactive immunoglobulin G, which has recently been suggested as a potential novel marker for diagnosis of AIH both in adults and children. However, in these previous studies, patients with DILI underrepresented, and therefore the authors investigated a new set of patients, including patients with drug-induced autoimmune like hepatitis and DILI. The results showed significantly higher levels of polyreactive IgG in autoimmune hepatitis patients and also in drug-induced autoimmune like hepatitis compared to DILI and other liver diseases, as well as in those who received immunosuppression compared to untreated patients. In addition, the diagnostic fidelity of polyreactive IgG was found similar to that observed for ANA and SMA by indirect immunofluorescence for AIH diagnosis. Another potential new diagnostic testing comes from a Greek study which showed that the Metabolomics signature by proton NMR spectroscopy can discriminate autoimmune hepatitis both from healthy controls, as you see in the left bottom of the slide, and also from other liver diseases, including patients with MAS, as you see in the right upper of the slide. In addition, the authors were able to identify 15 metabolites with 95% sensitivity and 92% specificity in discriminating autoimmune hepatitis from disease controls, concluding that proton NMR could be used as an additional specific tool for AIH diagnosis, but also to study its pathogenesis. Here is a large multi-center study in autoimmune hepatitis and PBC liver biopsies, which tested by deep learning analysis. The results showed that this novel artificial intelligence model, both in the training set and an external validation set, as you see in the left bottom of the slide, can discriminate AIH from PBC directly from digital pathology slides. Here is a study from the retrospective registry of the International Autoimmune Hepatitis Group, which investigated the potential association of the time to complete biochemical response and disease progression. As you see in the results in the left upper of the slide, the overall survival in patients who achieved CBR at any time was excellent, being better for those patients without cirrhosis at baseline. However, patients who never achieved CBR had a higher risk of progression to cirrhosis and liver-related death or liver transplantation. And in the right part of the slide, you can see that the risk of the progression to cirrhosis was significantly higher in those patients who achieved CBR in more than 6 months. However, the liver-related and liver transplantation-free survival was affected only in those patients who achieved CBR in more than 12 months. Regarding monitoring of AIH, here is a large multi-center longitudinal study for the investigation of the usefulness of LSM by FibroScan in predicting clinical outcomes. You see here the inclusion criteria and also the primary composite endpoint. And in the right part of the slide, you see the excellent results regarding the event-free survival for those with LSM less than 8 kilopascals and worst for those with an LSM above or equal to 14 kilopascal. Another interesting paper on outcomes of AIH regarding the risk of extrahepatic malignancies comes from South Korea with the analysis of a huge number of AIH patients. More than 7,300 patients were matched, age and sex matched with a control population. For this investigation, the results showed that the overall risk of extrahepatic malignancy between the two groups were not statistically significant. However, autoimmune hepatitis was associated with specific extrahepatic malignancies, namely thyroid cancer, non-melanoma skin cancer, lymphoma and myeloma, with the last two not being associated with the use of immunosuppression. In terms of PBC, an elegant study from the European Reference Network Prospective Registry in 316 patients investigated the current diagnostic and therapeutic trends in PBC patients. The results showed that PBC patients are currently more often diagnosed at milder disease stages, as attested by the fact that only 8% of the patients had already established cirrhosis at the time of diagnosis. However, a limited access to second-line therapies was observed from this analysis, as attested by the fact that only 37% of non-responders did receive a second-line therapy, which means that we need motivation for both the healthcare policymakers and also physicians and patients. Taking into account the results of this study, this study was conducted in order to create a question prompt list, a QPR, for individuals with PBC, covering key topics to be asked during outpatient consultations. After a Delphi method and two in-person meetings, an international PBC expert consensus was reached on a QPR containing 8 key questions, as you see in the orange table of the slide. And here you can see relative questions. A question regarding the previous study I showed you is the third one: do I need any therapy in addition to also the oxyholic acid? Regarding PBC therapeutics, here is a long-term real-world multi-center study from UK which assessed the effectiveness, safety and tolerability of obeticholic acid as the approved second-line treatment in the treatment of PBC patients. Prospectively collected data from August 2017 to December 2023 in patients requiring OCA were included, and the results, as you see in the left bottom of the slide, showed that the discontinuation rates were high. However, for the patients who remained on the drug, there was a sustained biochemical response over 4 years of follow-up, which led to significantly better event-free survival for those patients who met the POISE criteria after 1 year of OCA administration. Here are the interim results of an ongoing open-label long-term ASSU safety study seladelpar in patients with PBC and compensated cirrhosis. And you see here in 35 patients with cirrhosis at baseline the excellent results regarding the composite biochemical response and also the changes on alkaline phosphatase from baseline values in the long term. Here is the efficacy of elafibranor in PBC patients according to other than the POISE criteria biochemical response from the phase 3 ELATIVE trial. The results, as you see, further demonstrate the treatment efficacy of elafibranor, which was independent of the response criteria used. Considering PSC, here is a large study from Canada investigating the clinical outcomes in more than 1,000 patients with PSC and IBD compared to IBD patients, and the results in the left bottom of the slide showed a significantly higher incidence of deaths in PSC and IBD patients compared to IBD at a younger age, and this was mainly due to the significantly higher burden of hepatobiliary malignancy in these patients. In the right part of the slide you can see that PSC and IBD patients characterized by higher IBD-related surgeries, of course, hepatobiliary malignancy, and also GI malignancy. But very interestingly, the burden of hepatobiliary malignancy and IBD-related surgeries was higher in those diagnosed first with IBD and then PSC compared to PSC and then IBD. Here is a nice study in more than 600 patients with PSC from the Polish prospective PSC registry, where the authors tried to construct an original PSC cholangiocarcinoma risk prediction model using machine learning techniques. Actually, the authors were able to identify a combination of clinical and serum variables, namely some autoantibody seropositivity, common laboratory parameters, and also the diagnosis of IBD as cholangiocarcinoma risk factors, and then constructed a novel artificial intelligence algorithm to estimate the risk of the development of cholangiocarcinoma in patients with PSC. But of course we need further external validation before a routine screening on this. And my last slide will deal with the final results of the FICUS study on the prospective validation of the prognostic value of liver stiffness measurements by FibroScan in more than 500 patients with primary sclerosing cholangitis. As you see in the right part of the slide, according to previously established cutoff liver stiffness, patients with liver stiffness up to 9.5 kilopascal had excellent survival probability, while those with more or equal to 14.4 had the worst probability, survival probability. But most importantly, the predictive performance of liver stiffness at baseline was stable over the years, concluding that these findings support, of course, the use of LSM by FibroScan to assess PSC outcome, but also probably to underscore its major role in clinical trials as a risk stratifying tool and potential surrogate endpoint. Of course, the next step should be the assessment of the longitudinal dynamics of liver stiffness changes. Thank you.